A 28-year-old woman presents with intermittent double vision and difficulty chewing by the end of the day. She reports that her symptoms worsen in the late afternoon and improve after rest. Over the past month, she has noticed drooping of her eyelids, difficulty smiling in photos, and trouble keeping her eyes open while reading. She states she often feels fine in the morning, but becomes progressively weak by evening. She denies numbness, tingling, or difficulty walking, but feels her speech becomes slurred after prolonged talking. She has no significant past medical history, takes no medication, no family history of neuromuscular disease. She works as a teacher, and her symptoms interfere with long workdays, and she does not smoke or drink alcohol. On physical exam, she is alert and oriented. She's got ptosis that worsens with upward gaze, diplopia on sustained lateral gaze, facial weakness when asked to smile, nasal fatigable speech after prolonged talking, normal reflexes and normal sensation, and normal gait and coordination. Her vital signs are normal and there is no respiratory distress at rest. Her symptoms show fatigability, weakness that worsens with activity and improves with rest. A key clue. What is the diagnosis? Myasthenia gravis. Her initial labs are unremarkable. Two key tests return. She is positive for acetylcholine receptor antibodies, and the hydrophonium tensilon test shows transient improvement in her ptosis. A chest CT is ordered to evaluate for thymoma. This patient's presentation is classic for myasthenia gravis, an autoimmune disorder caused by antibodies against the acetylcholine receptor at the neuromuscular junction. In myasthenia gravis, antibodies block or destroy acetylcholine receptors, preventing effective neuromuscular transmission. The result? Repeated effort eventually leads to decreasing strength, and rest leads to recovery. Common exam keywords include ptosis, diplopia, fatigable chewing, slurred speech after prolonged talking, proximal muscle weakness, and symptoms that worsen by the end of the day. Always assess for respiratory involvement. Rapid worsening of weakness, difficulty swallowing, or dyspnea can signal myasthenia crisis, requiring ICU level of care. Treatment is aimed at improving neuromuscular transmission and reducing autoimmune activity. Pyridostigmine is the first-line symptomatic relief. Corticosteroids and immunosuppressants for long-term control. IVIG or plasmapheresis is used for myasthenia crisis, and thymectomy or thymoma for generalized myasthenia gravis. So remember, a young adult with fluctuating weakness, ptosis, diplopia, and symptoms that worsen with activity should immediately make you think of myasthenia gravis.